Hi, everyone. Thank you so much for joining us this evening for our AHNS Virtual Education Series. Tonight, we will be discussing new concepts for management of regionally advanced Merkel cell carcinoma in the head and neck. We all have our NCCN guidelines, but we hope that at the end of the night, you'll be able to better navigate those decision trees with current evidence. We're very lucky that we have a panel of experts tonight with representation from surgery, radiation oncology, and medical oncology. If you have questions, please put them into the Q&A box at the bottom of your screen, and we will get to those questions after all of our panelists have presented to you. I would like to briefly introduce our panelists in order of appearance. Dr. Sydney Ching. She is an associate professor at the Melanoma Institute in Australia and the Chris O'Brien Lifehouse Cancer Center at the University of Sydney. She has completed extensive training in plastic and reconstructive surgery, as well as head and neck surgery, craniomaxillofacial surgery, and another fellowship in head and neck surgery and reconstructive surgery. She has a background in research of the biology of skin cancers, and has been a part of changes to global guidelines for management of skin cancers. The next speaker we will have is Dr. Evan Wuthrick. He is a radiation oncologist at Moffitt Cancer Center, and he specializes in radiation therapy for cutaneous malignancy, including Merkel cell carcinoma. He is a residency graduate from Thomas Jefferson. He is a senior member at the Moffitt Cancer Center. He is a chair of NRG Oncology Radiation Oncology Committee, and he lives with his wife, Christine, and his children in Tampa. And then last but not least is Dr. Michael K. Wong, who is an oncologist, clinician scientist, clinical trial investigator, and serial biotech company founder. Dr. Wong is currently professor in melanoma medical oncology at the University of Texas MD Anderson Cancer Center in in Houston, Texas. He serves as executive director of integration and program development within the MD Anderson Cancer Network, and he has clinical interest in cutaneous malignancies, including melanoma, Merkel cell carcinoma, basal and squamous cell carcinoma. He also has a PhD in experimental pathology and an MD from the University of Toronto. I will be moderating tonight. I'm Brittany Tillman, and I am a head and neck surgeon and associate professor at the UT Southwestern Medical Center in Dallas, Texas, where I serve as our current fellowship director. Thank you all so much for joining us tonight. And with that, I will turn it over to Dr. Ching to get us started.
Thank you very much, Brittany, for the kind introduction and the invitation.
Sorry. So Dr. Ching is really going to touch on our first objective tonight, which is appraising the approach and current evidence for the application of sentinel lymph node biopsy and management of regional nodal basins following a positive sentinel lymph node biopsy.
Next slide, please. So I have advanced on the objective to include management of primary Merkel cell carcinoma, the application of sentinel node biopsy, and the management following regional nodal basin following sentinel node biopsy. Next, please. I have decided to present a case, a relatively recent case, because of the many teaching points it offers. So in July 2021, I was referred a 78-year-old female with a biopsy-confirmed Merkel cell carcinoma in her right nasolabial fold. When I saw her, she already had the defect reconstructed with a VY advancement flap, and she was not keen on further surgery. Microscopically, the lesion was narrowly excised with a radial margin of 2.7 millimeter and a narrower deep margin at 0.4 millimeter. The lesion was reported as a 8 by 7 millimeter lesion centered within the dermis with no lymphovascular invasion, but an infiltrative pattern. So if we look at some of the adverse prognostic features here, She's great. She's older than 75 years old, and that is one bad prognostic feature. This is a lesion in the head and neck region. That's another one. And the third would be an infiltrative pattern. She doesn't really have many other adverse prognostic features, including Merkel cell carcinoma in men, greater than 2 centimeter, lymphovascular invasion, deep invasion beyond the dermis, immunosuppression, especially CLL or HIV. There wasn't a positive margin, even though it was narrow. And unfortunately, tumor mitotic rate was not actually reported. And as we know, this lesion is not uncommon. Just to put things in context, Merkel cell carcinoma, even though it is a rarer skin cancer, in Australia, it is still one of the commoner rarer skin cancer, together with microcystic adnexal carcinoma, sebaceous carcinoma, dermatofibrosarcoma, protuberance, pleomorphic dermal sarcoma, as well as cutaneous angiosarc. And it is not uncommon either. This lesion was originally thought to be a basal cell carcinoma. That was why it was actually excised by the external provider and the defect reconstructed with a local flap. As we know, Merkel cell carcinoma can be very easily confused with a squamous cell carcinoma, could be confused with amelanotic melanoma, adnexal tumor, and even primary cutaneous B-cell lymphoma. Next slide, please. So I referred her for lymphoscintigraphy for mapping of the sentinel nodes, respecting her wishes that she did not want any further surgery. 4 sentinel nodes were marked in her right submental region, right submandibular, and right neck level 3. I then referred her to a radiation oncologist closer to home. She actually lives 6 hours away, and she only underwent radiotherapy to her primary site. Next slide, please. So if we look at the current evidence for margins of excision, the wide local excision versus most controversy. Currently, we know that there is no randomized controlled trial looking at either modalities for Merkel cell carcinoma. However, in a meta-analysis of 40 studies looking at wide local excision versus Mohs surgery, and of the 40 studies, there were 31 on wide local excision, 3 on Mohs surgery, and 6 on both modalities. We knew that the local recurrence rate was similar between both, 6.8% for the wide local excision versus 8.5% for Mohs, and the regional recurrent rates were very similar as well at approximately 15%. So currently there is, for stage 1 Merkel cell carcinoma, Mohs surgery versus wide local excision, the jury is still out. Next slide, please. As for the margins for wide local excision, similarly, it is unclear. There are studies, and the first one, Yen et al., is a STEER study looking at 2 centimeter or less versus greater than 2 centimeter excisional margin. And in that study, there was a statistically significant overall survival for the greater than 2 centimeter wide excision margin. In another study looking based on the National Cancer Database, looking at 1 centimeter or less versus greater than 1 centimeter, again, there was a statistically significant overall survival for the cohort greater than 1 centimeter. The limitation with both studies clearly is the lack of cause of death. So nothing could actually be commented on disease-specific survival. And both studies had approximately 6,000 to 7,000 patients. In a much smaller retrospective cohort study of 0.5 to 1 versus greater than 1 centimeter followed by radiotherapy, there was no statistically significant survival advantage in disease-specific survival, recurrence-specific survival, or overall survival between the two, narrow margin or greater than 1 centimeter followed by postoperative radiotherapy in about 250 patients. But what is quite clear, though, at least based on consensus studies, consensus guidelines, are that clear pathological margins are needed. Next, please. In the larger study so far, looking at the role of adjuvant radiotherapy in close to 7,000 patients in a meta-analysis, in a study looking at almost 7,000 patients from the National Cancer Registry, we know that surgery and adjuvant radiotherapy was associated with a statistically significant improvement in overall survival compared with surgery alone in stage 1 and stage 2. Next slide, please. So if you look at the top two slides for stage 1 and stage 2, and the dashed line represents the graph adjusted for variables, one could see that there is a survival advantage for postoperative adjuvant radiotherapy for stage 1 and stage 2 Merkel cell carcinoma, but that advantage is somewhat lost in stage 3 and stage 4. I think there is actually a print error in the bottom right graph. So in stage 3 and stage 4, it is estimated and believed that subclinical distant metastases in those two stages have actually got a greater impact in the eventual prognosis. Next slide, please. So the current NCCN guidelines state that the goal of wide local excision will be to obtain a histologically negative margins when clinically feasible, but surgical margins should be balanced with morbidity of surgery. And in an area where wider margin is not feasible, postoperative radiotherapy is strongly advised. Next slide, please. Now, in this case, the patient refused further surgery, but even if she had agreed to further surgery, I would then be faced with the conundrum of how reliable sentinel node biopsy would be in her case, in that she already had a VY advancement lab when she came to see me. But we know that sentinel node biopsy is currently the most reliable staging procedure for identifying subclinical nodal disease, and it enables detection of micrometastases in approximately a third of cases with clinically negative nodes, about 20% for T1 and about 40 to 50% for T2. And if you were to consider clinical staging with PET-CT, we know that PET-CT in clinically negative as well as clinically positive Merkel cell carcinoma case at baseline will upstage about 16.8% of patients, between 15 and 20% of patients. So PET-CT still does miss a portion of sentinel node positive cases. Next, please. Sentinel node biopsy carries a false negative rate of 17.1% and has been observed specifically in immunocompromised patients or with Merkel cell carcinoma located in the head and neck or midline trunk region. Isolated regional nodal metastasis is the commonest first site of metastasis at 75%, and distant metastasis is very rare in the sentinel node negative population. Next slide, please. And the 5-year overall survival in Merkel cell carcinoma patients have been reported at 48 to 63%, and clearly it worsens with increasing stage. And surprisingly, in those with no known primary tumor, or not surprisingly, it actually has a better survival at 5 years, at 68%. And this is actually different from melanoma, where there's actually no difference. Next slide, please. So the role of sentinel node biopsy at our center is actually to avoid unnecessary treatment. In patients with stage 1 and stage 2 Merkel cell carcinoma, it has been shown that there is no significant difference in regional recurrence rate with or without adjuvant radiotherapy if the sentinel node is negative. Next slide, please. But radiotherapy to the sentinel node field is recommended if radiotherapy is not carried out or if its accuracy is questionable. And again, this is consensus guideline without high-level evidence. Next slide, please. And this is NCCN guidelines following sentinel node biopsy or no sentinel node biopsy. So if there's no sentinel node biopsy, then the recommendation is to consider radiotherapy. Next slide, please. This lady then represented in March 2024, a few months ago, with clinically palpable right submandibular lymphadenopathy and was biopsy confirmed to be Merkel cell carcinoma. I got her screened for the NEO-MCC clinical trial, which is a clinical trial based at the Melanoma Institute Australia. It is a nivolumab and relatinib anti-LAG-3 trial in a neoadjuvant setting, followed by surgery in 6 weeks. But she was deemed inappropriate for trial based on potential cardiac toxicity and just underwent radiotherapy to her right submandibular region and rest of the neck. She also declined, subsequent to that, discussion of clinical trial with potential post-operative adjuvant radiotherapy. With that, I'm going to hand over to our second panelist of the day, and I think it segues very well into his presentation. Thank you.
Thanks, Dr. Ching. So my name is Evan Wuthrick again, and I'm going to take you through objective number 2 for tonight's talk, which is to talk about the role of radiation therapy to the cervical lymph node basin for regionally metastatic or positive sentinel lymph node biopsy, Merkel cell carcinoma. So we're kind of going to take it into 3 different parts. Next slide, please. So I want to try to sort of address 3 questions. In a patient who has a positive sentinel lymph node biopsy, should we observe them? Should we give them postoperative radiation therapy, or should we do a nodal dissection in the draining basin? And then the second question I want to try to address is what's the role of elective nodal radiation if a sentinel lymph node biopsy is unsuccessful or deferred? And then thirdly, is there a role for definitive radiation therapy in patients with macroscopic stage 3 disease? Okay, so next slide, please. All right, so just as Dr. Ching talked about, really radiation therapy is a great treatment for Merkel cell carcinoma. Merkel cell carcinomas and lung cancers are uniquely radiation sensitive, much more so than melanoma, which a lot of us also treat. And so it's a whole different ballgame when thinking about radiation therapy for Merkel cell carcinoma because it's such a better treatment. Here's just data from our own institution looking at head and neck Merkel cell carcinoma and the better survival rate that we see in patients that get radiation therapy versus those that do not. And then also Dr. Ching, next slide, talked about the NCDB database study, which obviously it has its pros and cons, these kinds of studies, but it gives us an ability to look at nearly 7,000 different Merkel cell carcinoma cases and draw big, sort of maybe big picture kind of things. And so I think a big picture thing you can draw from that is, man, Merkel cell carcinoma is pretty sensitive to radiation therapy. And when we use radiation therapy, it seems like just in general, patients do a little better. Next slide. All right, now to our specific questions. So question number 1 was, what should we do after a sentinel lymph node positive biopsy? And so we looked at this at our center, and we divided. We looked at all cases for 17 years at Moffitt, where we looked at all the stage 3 Merkel cell carcinoma patients that had a positive sentinel lymph node biopsy. They were detected by lymph node biopsy, not because they had macroscopic disease. And we divided them into either those that got a complete lymph node dissection or those that got radiation therapy after their sentinel lymph node biopsy, or those that had both. And this does include both head and neck as well as axillary and inguinal lymph node basins. Next slide. And what you can see is that there was not even distribution among the groups, and but the patient population that we had is pretty typical, at least for American Merkel cell carcinoma population. So it was 3/4 male, median age was 76, going as high as 90, and about 1/3 of the patients overall were head and neck. So we had about 1/3 head and neck, about 1/3 axillary basin, and about 1/3 inguinal basin, just roughly. Next slide. What you see, first of all, is that there was a higher risk group of patients that were treated both with surgery and radiation therapy, which kind of makes sense. We took, we basically had a bias, right? And we said, well, the people who have the most disease, they're probably going to do the worst. So maybe they need multimodality therapy. And so you can see if you look at the percent nodal involvement line there, median percent nodal involvement, that those that got dual agent regional therapy had 30% of their nodes involved. They were also much more likely to have extracapsular extension and other negative prognostic factors. Next slide. Yep, next slide. Thanks. One more. And what we found was that the median follow-up for these patients was about 2 years, and we had 4 recurrences in the nodal basin. So 3 out of the 40 that had radiation therapy to the nodal basin recurred, percentage of about 7.5. 1 out of 20 with both lymph node dissection and radiation therapy recurred, and none of the 11 patients with a completion lymph node dissection. We couldn't find any significant correlations between any other important risk factor or treatment group. So this was not more likely to happen in any other kind of particular patient. Next slide. Similarly, the distant metastasis-free survival was all pretty similar between the two groups. Basically, about 15 to 20% of these patients will end up with a distant metastasis. Next slide. And here are the curves as they pertain to overall survival. These are not statistically significantly different. Next slide. Next slide. What we also did in a more limited fashion was take a look at some toxicities to try to see if that could help us determine what the best treatment for these patients is. About a third of patients get significant moist desquamation or grade 2 dermatitis in the skin. Of the lymph node dissection patients, there was about 20% surgical site infection, and symptomatic lymphedema occurred in 2 of the patients who had both a complete lymph node dissection and radiation therapy, so a rate of about 10% or so. Next slide. So what have we concluded from this look back at our practice? Well, we actually concluded that our management of the lymph node basin is pretty good, in that the nodal basin failure was low, less than 10% in all the treatment groups. And the morbidity really was pretty low also. Patients with angiolymphatic invasion were more likely to be treated with radiation therapy. There's a trend towards higher burden of nodal disease in the patients who got combined therapy. So we felt like we were doing a decent job of picking the patients that needed dual modality regional therapy. The toxicity data was not collected in a prospective, systematic manner, so I'm not sure you can make more robust conclusions about it than that. All right, next slide. Okay, so the answer to the first question, I think, is that patients who have who truly have like sentinel lymph node detected microscopic disease in that draining nodal basin, they can be treated either with a lymph node dissection or with radiation therapy. However, we tend to treat more of these patients with radiation therapy than a lymph node dissection, because many of these patients are going to be getting a course of radiation for their primary anyway, and so it feels like many patients will choose to have radiation therapy in this circumstance. And then we think that patients with macroscopic disease, our treatment paradigm for stage 3 macroscopic disease patients is for them to have both a node dissection and postoperative radiation. Okay, so let's talk about the second question now, which is, what is the role of elective lymph node radiation if the sentinel lymph node biopsy can't be done or is unsuccessful? The way to look at this, one thing we can do is to look at one of the few randomized trials in early stage Merkel cell carcinoma. And this was what I refer to as the Johari study. And basically, it looked at stage 1 Merkel cell carcinoma patients that had a wide local excision. And this happened before the era of sentinel lymph node biopsy. In fact, this trial did not finish its accrual because sentinel lymph node biopsy was invented. And so it kind of became a little bit of a moot point. But group A in this study was randomized to radiation therapy of both the tumor bed, so the primary bed, as well as the lymph node basin. And group B was just the tumor bed only, so there was no elective nodal radiation. Next slide. And like I said, this study overall kind of had a failure to launch because of the advent of the sentinel lymph node biopsy technique. Next slide. But there were 70 patients overall that were accrued and went through the study paradigm. And basically what you can see is that the rates of recurrence are super low. There's low local failure rates after radiation therapy. Next slide. This is the Kaplan-Meier event plot for regional recurrence probability, and you can see that all of the patients that underwent elective nodal radiation maintained good control in the regional nodal basin, whereas those that just had observation of the elective nodal basin and no radiation therapy had about a 16, 17, 20% risk of recurrence. And that makes total sense, actually, because as Dr. Ching pointed out, the rate of sentinel lymph node positivity, I mean, it matters about, depth of tumor and diameter of tumor, probably, but also it just sort of, if you look across all studies, it's about somewhere between 16 and 20%. So if you don't radiate the nodal basin and you don't do a sentinel node biopsy, about 16 to 20% of those patients are going to have a nodal basin recurrence. Next slide. This did not, however, at least in this small study that was underpowered, did not affect progression-free survival or overall survival. Next slide. Okay, so what can we learn about this? Well, I would say that a good number to keep in your mind is that if you don't have a sentinel lymph node biopsy, you don't have elective nodal radiation, there's a 15 to 20% risk of recurrence in the draining nodal basin. And whether that's a high enough risk or not to treat the elective nodal basin with radiation therapy or not is kind of in the eye of the beholder. That means that you have a nuanced discussion with the patient, try to get a sense of their what their goals are, whether how adverse they are to morbidity. Talk about what the morbidity would be. Obviously, like treating axillary lymph nodes is a lot less morbid than treating head and neck lymph nodes. Couple things to mention though is what's missing from this study is whether nodal ultrasound surveillance can further reduce this risk. So this study was done quite a while ago, so there wasn't PET scans, there wasn't nodal ultrasound surveillance observation, and a lot of our centers have gotten pretty good at lymph node ultrasound and surveilling those lymph nodes and keeping an eye on those lymph nodes and being able to detect pretty early when they might have tumor in them. So it's possible that we could forego elective nodal radiation and still do okay if we're using nodal ultrasound surveillance, but I think that's a good area for scientific inquiry. Certainly, if the primary tumor is near the lymph node basin, this makes it a whole lot more practical to do elective nodal radiation. And sometimes that's one of the cases when the sentinel lymph node biopsy will fail, right? Because if the tumor is right on top of the basin, sometimes, obviously with the radio tracer, that doesn't help you that much. And then, scalp cases and other, midline anatomical sites may make elective nodal radiation impractical because it may be very hard to determine, for the same reason that the sentinel lymph node biopsy didn't localize, maybe the same reason why it's hard to decide what the elective nodal basin would be. And I don't really recommend going and chasing a bunch of different nodal basins. All right, next slide. Next slide. Next slide. Okay, so let's going on some pretty thin amount of data. Our standard, like I said, was to have a lymph node dissection followed by radiation therapy. However, you can, if you take a look at this publication from 2017, this is a large, kind of takes all of these retrospective series and takes a look at the infield recurrences and the regional recurrences. And similar to the NCDV study, is just a chance to look at a larger number of patients. In this case, there's 160 patients amalgamated here, and the regional recurrence rate is 26 out of 160, so about 16%. So when you treat patients with definitive radiation therapy, about 5 out of 6 will have long-term control of the nodal basin. And that's really that. Not only is that here in this paper, but I think that's about right with our experience. When we treat patients with macroscopic nodal disease, there's really pretty good control of the draining nodal basin with radiation therapy, even sometimes when they have bulky disease. Next slide. Okay, so let's do a little summary. So for microscopic, so positive sentinel lymph node biopsy, we recommend completion lymph node dissection or adjuvant radiation therapy. And generally, more patients will go down the adjuvant radiation therapy arm of this. We usually do at least offer or talk about elective nodal radiation in those sentinel lymph node biopsy deferred or couldn't localize cases. And then for macroscopic disease, we use usually both complete lymph node dissection and adjuvant radiation therapy. For those patients who are not good surgical candidates, or there's some other reason why they're not a good candidate for surgery, we don't think that definitive radiation therapy is a terrible option. And then we're awaiting, and this is kind of a segue into Dr. Wong's talk, we're kind of awaiting results of STAMP and ATOM trials to determine the role for adjuvant immunotherapy. And there's probably a developing role for neoadjuvant immunotherapy in the right patients with very local regionally advanced disease. Next slide. So thanks so much, and I'll turn it over to Dr. Wong.
Great, thank you very much. And it's my honor and pleasure to be able to speak with you today about this incredibly new changes in Merkel cell carcinoma. Next slide, please. And next slide, please. Here are my disclosures. Next slide, please. Three things I want to talk to you about: the role of Merkel cell polyomavirus testing and workup and surveillance, the role for systemic therapy in locally advanced non-distant metastatic Merkel cell carcinoma, and what are the new treatment paradigms that are emerging that will impact you in the near future. Next slide, please. Just hit advance, please, 3 times. So analysis of 100,000 human genomes show that skin cancers have a very high mutational rate. And in fact, hit the forward again, please. And one more time, and one last time. And you'll notice that skin cancers have one of the highest mutational rate, which accounts for its ability to respond to immunotherapy. And Merkel is right up there. In fact, it wasn't for the dilution that you get from the polyomavirus positive tumors, which we'll talk about in a few seconds, it may even be higher. So this is a genesis of why these tumors are responsive to immunotherapy. Next slide, please. Now, the thing about Merkel, which is different than almost any other cancer, is the role of the Merkel cell polyomavirus. It is ubiquitous in the population. And for the longest time, we thought it was just a inert passenger. You know, if it's on the skin and you get Merkel cell carcinoma, then it's going to hang around. But now we know that that's not true. The virus integrates into the DNA of the genome. There doesn't seem to be any viral hotspots, and it drives expression of large T antigens, promotes tumor proliferation, and disrupts immune response. And the next slide, please. If you look at Merkel cell carcinoma, there are 2 types. There is a polyomavirus positive and a polyomavirus negative. And the negative one actually looks like melanoma and squamous cell, has a large amount of UV signature DNA damage, high frequency of DNA mutations, high degree of aneuploidy, and all kinds of inactivating mutations. And on the polyomavirus positive side, you have expression of small t and truncated large T antigen. And most importantly, it is associated with almost 0 mutations in RB1 and P53 protein. Very interesting. So I tell my staff that if you came from Mars and you had to look at reclassifying Merkel cell carcinoma, you might actually call this something different. It doesn't matter clinically right now today, because the ability of these different types of polyomavirus or negative Merkel respond statistically identically to immunotherapy. Next slide, please. So you're going to see a few of these things come up, which summarize things, right? 2 different types: sun exposed, polyomavirus positive, and for tomorrow when you go to clinic, it doesn't matter for now. And in clinical trials, it does matter. But for the primary treatment, it does not at this point in time. Next slide, please. Well, what is the rationale for then using this angle to help you understand disease status in a patient? We know that if you actually have polyomavirus-induced Merkel cell carcinoma, your body reacts by forming antibodies against that. And if you actually have clearance of the tumor, then you reduce the push for the body to make antibodies against that, and you have a lower amount of antibodies in the blood. And if you have recurrence, or activation of tumor, you would then have antibodies concomitantly go up. So, so the best situation is to measure the antibody levels in someone pre-operatively and measure it post-operatively, and then you track it and follow it. Now, does that work? Is that really something that can help you? Can I have next slide, please? So these are the possibilities. In B, for example, are examples of individual patients who did not recur, and they show invariably a decrease in the they call it the oncoprotein antibody titer, and you notice it drops, goes down, and stays down. I point out patient W710, the second from the right, it goes down, but not to 0, for example. Now, number C are examples of individual patients who have developed recurrence of Merkel cell carcinoma, and in patient on the left-hand side, W853, it goes down to NED. Notice that the polyomavirus antibody oncoprotein doesn't go to 0, and there's a rise, which then signifies recurrence. Likewise, the other two patients. Next, hit the button, please. Here's the problem. The positive predictive value is a meager 66%, which means that if you do have a rise, your ability to predict recurrence is only 66%. And that has to do with a multitude of factors, including the fact that we use immunotherapy, which can change, and you're really not looking directly at viral particles, but at the body's reaction to that. So a lot of other host factors come into play. So next slide, please. So the Merkel polyomar virus serology does track with the presence of viral protein, but not necessarily disease status. And the worst case scenario, and there's several like this, if you speak to patient advocates, is that you have polyomavirus rising in blood, but your scans remain negative and negative and negative. So, so what do you do there? So, it's not ready for prime time. The gold standard is still to do scans and surveillance, as this is what we do. Next slide, please. So there are 3 FDA-approved PD-1 agents for use in Merkel cell carcinoma. The 2 that are in italics, nivolumab and ipilimumab, are used, not necessarily FDA-approved in the US. The other 3 are subjects of phase 2 studies, which have shown its efficacy and are FDA-approved in this setting. And notice that there are anti-PD-1 and an anti-PD-1 ligand one, which in the form of avelumab. Next slide, please. So here's an example. Here's someone that came into my office, had unfortunately a gentleman who worked in the agriculture industry, lots of sun exposure, had this very bulky Merkel cell. Next slide, please. Within 1 infusion, within 2 weeks, he already had some involution of this. And next slide, please. By number 5, he had a complete response. I should tell you, he also had something in the axilla as well, which also disappeared. And this patient only got about 7 cycles and was lost to follow-up. I recently saw him again. He's still in NED status. Next slide, please. Here's another example in a head and neck with a scalp Merkel, which was resected and then developed sometime later parotid gland metastatic deposit because of previous radiation. This gentleman had a history of treated lymphoma. He was NED from his lymphoma. We had the situation where we couldn't do radiation and he wasn't a surgical candidate. We gave him avelumab therapy. He's been off therapy a year from treatment and he continues in response. He's now 7 years out, unmaintained response. So just a complete response that didn't need to be further sort of maintained. So the best of possibilities in this man. Next slide, please. So this is something you should never do, but I'll do it here as long as you don't tell anybody. This is where you take parts of different clinical trials and you stick them together side by side. And I'll say officially that you shouldn't do this because they're different patient populations. But I want you to get you a sense of what we're dealing with here. The pembrolizumab Keynote 017 trial in first line in advanced Merkel is on the extreme right, and the avelumab Javelin trial Part A and Part B is on the left two columns. Next slide, please. You see the overall response rate is fairly robust, and the 71% and in average, almost 60% on average through multiple studies, represents one of the highest response rates of all solid tumors to an anti-PD-1 agent. Let me just say that again. It's one of the highest response rates of all solid tumors to an anti-PD-1 monotherapy. That's extraordinary in Merkel cell carcinoma. Next slide, please. All right, and then there's a complete response rate. And in the Part B, which is first-line therapy, you have this incredible, almost 1 out of 3 patient with a complete response to the treatment, as I showed you in the previous slides. Next slide, please. These are the oncologists love showing these. These are the swimmers plots, and they sort of array for you sort of a sense of what's happening each individual patient. So each line is an individual patient. And the thing that's important are that the vast majority, this is from the initial publication, and you see down there what the references are. These are ongoing responses. So most patients who do well continue to do well. And here's the kicker: well in advance when it's going to happen. By the first scan or sometimes before, right? Just as I showed you previously. So unlike some other skin cancers, basal cell, for example, is an example, which can have long indolent time until response, and quickly. Next slide, please. So anti-PD-1 and PD-1 ligand therapy in Merkel cell carcinoma possesses one of the highest response rate in solid tumor oncology. There's no statistical difference in response rate of viral positive or negative, so it should not be a differentiating factor, at least in the first line with immunotherapy. And there's no difference in the anti-PD-1 or PD-1 ligand. So people say, do you use Pembro? Do you use avelumab? Clinically, doesn't seem to matter, but there's some new data coming out from the preclinical studies which may influence our decisions. Again, not ready for prime time, but stay tuned. Next slide, please. So despite the fact that you can have localized Merkel cell carcinoma, i.e. stage 1, this is from an older AJCC, but I showed this this is in a pre immunotherapy era, but I showed this to impress upon us all that even localized tumors can be very deadly. And so the idea of neoadjuvant therapy comes to the forefront. Next slide, please. And so a study was done. This is a study published by Jürgen Becker. And what was shown is that this is a 2-country study. Most of the centers were in Germany, 19 academic centers, 1 center in the Netherlands. And basically, bottom line is these are individuals with Merkel cell carcinoma that were treated definitively locally. So you had definitive local treatment. And then afterwards, they were randomized in a 2-to-1 fashion. Next slide, please. In a 2-to-1 fashion to either getting nivolumab adjuvant therapy, or what they were doing there was observation. Next slide, please. I want to point out that these are not all advanced patients. A good number of them were stage 1 and 2s in the study, and this may impact how you interpret the results that I'm going to talk about in the next slide or two. Next slide, please. Yeah, there you go. Surgery and radiotherapy were dominant in this treatment, were dominant in this group. Next slide, please. So here's the Kaplan-Meier graph showing the observation group in red and the treatment group in blue. And you'll see that there is a difference of, next slide, please, 9% at the 1-year landmark. Next slide, please. And 10%, these are absolute differences at the 24-month mark. One of the critiques of the study was that if you had loaded up high-risk patients in the study, your curves would look better because then you would show a better difference, right? As the higher the risk, the more the treatment effect can be seen. And but nevertheless, this is something which is really sort of permeated into the field. And this very recent publication has changed the way we looked at immunotherapy. Now, the ATOM trial and the STAMP trial, the ATOM trial is a randomized control study. Data is not yet out yet, but this gives us a hint already that adjuvant therapy may be helpful, and it should not be surprising to you given what you saw already about the tremendous response rate and responses you can get with bulky stage 4 disease. Next slide, please. This is a subgroup analysis. And what's important, next slide, please, is that, the scalp, head, and neck tumors tend to be favorably impacted by adjuvant therapy. Next slide, please. And of course, even low stage disease, because the more to the left you are, the bigger the treatment effect. Even localized disease is and low stages is impacted. So it seems that you have benefit through and through the whole staging of advanced Merkel cell carcinoma. Next slide, please. And lastly, radiotherapy seems to be impactful, and you saw that yes, where it says yes, there's a shift to the left, more so than no. So there's always a suspicion that radiotherapy can synergize with the immunotherapy, and this is a little bit of a hint that if you got radiotherapy, the benefit of adjuvant therapy may be higher. A hint, and remember, subgroup analysis is always a curse because you're basically sort of parsing through the data to find stuff, which is not statistically sort of robust, but it is hypothesis generating. It supports many of our biases that there is something between radiotherapy and immunotherapy. Next slide, please. And this is sort of whenever you treat patients in the adjuvant setting, you always have to be cognizant of the side effect profile. And so before you rush off and give everyone immunotherapy, next slide, please, be aware that any adverse event leading to discontinuation you saw here is 22%. Next slide, please. And serious adverse events are up to 27% in the treatment group. So remember, immunotherapy is not inert, and some of the side effects can be long-lasting and permanent. So careful thought to putting patients on this, and you have to have a careful parsing of risk and benefit. Next slide, please. So adjuvant nivolumab, 10% advantage in disease-free survival. There's no overall survival data yet, and that's going to be very important. And careful assessment, risk versus benefit, knowing the toxicity. Next slide, please. Here's an example of one of my patients who on the left-hand side came to me with advanced disease. He had it everywhere: liver, spleen, bones, mediastinal lymph nodes, everywhere, subcutaneous nodules. And with 3 cycles of ipilimumab, nivolumab, you get the middle one, which is clearance. And then, of course, this has maintained response with maintenance nivolumab monotherapy. So the incredible potency of dual checkpoint inhibitors. And I point out that this man had failed 3 previous lines, including chemotherapy, anti-PD-1, and combination anti-PD-1 and chemotherapy before we started down this path. Next slide, please. So is this helpful? Well, there's retrospective on the left-hand side, retrospective salvage, which shows you Kaplan-Meier-wise, hey, that looks like a pretty flat graph. Maybe there's some long-term advantages to it. But then the folks in the middle segment for the Mass General showed, well, not so great. Next, you hit the next slide button, please. Right, flat curve. Next slide. Next slide. And you get to sort of diving down the curve that they had very poor response. And of course, there was a phase 2 study adding IPI to Nivo in a frontline setting without any benefit. And so how do we interpret this? First of all, when we looked at the data, the folks from the Mass General, which is in the middle, more heavily pretreated, more previous therapies, and basically a sicker bunch of folks. The retrospective salvage study seems to show folks were less heavily pretreated. And then the right-hand side shows us that when you have a response rate already close to 70%, adding IPI is not going to make it any better. So the standard of care now is to do frontline single agent PD-1, and the jury is still out on whether or not adding IPI to Nivo in the salvage setting is useful. The reason why we're going through here is that in melanoma, IPI and Nivo as neoadjuvant therapy is now becoming the thing to do, and it's probably not going to be the case in Merkel given the high response rate to single agent PD-1. Next slide, please. Yeah, next slide, please. So here it is. I already talked to you about this. Next slide, please. what about these unresectable Merkel cell patients who stage 3 are outside the radiation field? And what about these fragile patients that are, because on average, Merkel patients are a decade older than melanoma patients. Next slide, please. Here we have a clinical trial of intratumoral oncolytic intratumoral oncolytic therapy, where you inject directly into a tumor. Left-hand side are these large, bulky tumors, and on the right-hand side, you have a phenomenal response in the forearm lesions, and the big bulky one on the inferior surface of the proximal arm actually after this picture was taken actually dried up and fell off. So here's an example of what's happening in the field where we are now using oncolytic type strategies with very, very low toxicity rates in recalcitrant or recurrent tumors. Next slide, please. So multiple clinical trial options in the immunotherapy space: adoptive T cell, third generation, like Opdualag, NK cell targeted therapy to the Merkel polyomavirus protein pathways. And I will urge you that after failure of frontline therapy, that these patients should be, with a rare tumor, should be put on clinical trials. Next slide, please. And that's my final slide, and I turn it back to the panel. Thank you very much.
Thank you. Thank you, Dr. Wong. Next slide, please. So these are our knowledge gaps in management of Merkel cell carcinoma. We are short on time, and we do have some questions to get to. So we're just going to leave this up for now for you all to read. And I'm going to answer or get to some of these questions so that our panelists can answer them. The first question I think is probably most appropriate for Dr. Wuthrick. This question is from Dr. Randy Weber. The question is, if the sentinel lymph node is negative, but the primary is not low risk, adjuvant radiation will be necessary. Do you also cover the first echelon of nodes? For example, the parotid, if the primary lesion would be in the parotid drainage basin?
No. In routine practice, we do not. We trust the sentinel lymph node biopsy unless there's real reasons to not. So if a patient is sentinel lymph node negative, then we omit elective nodal radiation altogether and just treat the primary. However, primaries are generally treated with pretty wide margins to try to catch in-transit lymphatics and microsatellites. So even on the head and neck, we try to get at least 3 centimeter margins around the primary tumor, and if possible, 5.
Thank you. I will move on to my next question. I think Dr. Wong would be great to answer this one. And perhaps Dr. Wuthrick as well, you can comment. Given high PCR rates of advanced Merkel cell carcinoma, so stage 3 or higher to IO, at least as high as cemiplimab or for cutaneous SCC, why are there not more trials of neoadjuvant IO for management of advanced MCC? We have seen IO salvage recurrence after RT. Why not spare patients the morbidity of RT?
I think those trials are ongoing, and we are both initiating our own in-house and also collating our neoadjuvant experience. We actually backed into the neoadjuvant space because, as you know, Merkel's are fast-growing, rapidly growing tumors, and oftentimes our surgical colleagues would come to us and say, could you do something here? So we have both use data that we hope to get out soon, but also joining up with other folks to do a neoadjuvant trial.
To piggyback on that, just for me, do you see the same clinical response or similar clinical response timeline for cutaneous malignancy, kind of that 3 to 4 cycle range, or are you seeing something different with the Merkel cell population?
So Nina, we see, I think what we're coming to understand is that if it's going to respond, it's going to respond quickly. Our neoadjuvant protocol is to only give 3 cycles of avelumab. We just happen to have a lot of experience with avelumab, nothing against Pembro, and that's every 2 weeks apart. So you really have a very quick turnaround, and you often see something happening well before your 3rd cycle. I always joke with my surgeons that my job is not so much cytoreduction, but to deliver to my surgical colleagues the best physiologic specimen for surgery. So we try to avoid getting into autoimmune toxicity trouble, which oftentimes statistically happen mostly after cycle 3.
I can comment on that too. Our approach has been pretty similar to what Dr. Wong just discussed. We have a couple of neoadjuvant immunotherapy trials for patients with macroscopic stage 3 disease. So we are looking at that. Obviously the total population of Merkel cell carcinoma patients is not that many out there. So it's a little bit, single institution studies where these are right now are going along, but they're, moving on at the pace of Merkel cell carcinoma research. And that's also our strategy too, has been just a few cycles of immunotherapy. We have actually a study that just one infusion. So yeah, they're pretty brief, yet we often get responses just in a short number of, small number of total infusions. And I guess what will need to be determined before this could really be used in practice outside of a clinical trial broadly is probably, a randomized or other way of comparing more standard regionalized therapy, surgery, radiation therapy versus a neoadjuvant approach, and see if we can improve toxicity. But it's not a slam dunk that necessarily a bunch of immunotherapy followed by a local therapy would necessarily be a better toxicity profile, which is why I think, like Dr. Wong was talking about, we're trying to limit the number of immunotherapy infusions. That might be the pathway of least amount of toxicity for most amount of gain.
I have another question. Can we go ahead and advance to the next slide, JJ? Perfect. These are the landmark study references in case anyone needs those. And the next question is, would you recommend intratumoral immunotherapy injection in organ transplant patients who cannot have systemic therapy? Great question.
Wow, so this is, as you know, that's a risk factor, both immunosuppression, both as a consequence of iatrogenic issues or due to autoimmune, intrinsic autoimmune diseases. We've done that. And there are clinical trials in the cutaneous squamous cell space to do that. And we've done that in sort of case-by-case basis here. We are going to mount a sort of with the sponsor's help, a clinical trial in this space once we sort of get better understanding of how some of the new oncolytics are performing. But that's exactly what we've done in several other skin cancers, including squamous cells and Merkel's.
Great. Thank you, Dr. Wong. And I don't want to let Dr. Ching completely get off the hook here. So you mentioned, and I think this is a common scenario, especially for our surgeons. You mentioned that this patient presented to you after they had had an excision, after they had had a V to Y reconstruction. I had a case literally just today that was already reconstructed. And how do you navigate that conversation about, or how do you feel about, number one, your sentinel lymph node accuracy? Do you have any tips or any thoughts on how the injection goes or where it goes, especially after a reconstruction? It always makes me nervous about how reliable these are.
I think in the setting of, if it's just a wide excision, I will feel more comfortable. If a local flap has been carried out, it's a lot more difficult, especially in the head and neck region. So in that case, I think it is tricky. In hindsight, in this patient, we probably would have pushed a bit stronger for radiotherapy, at least to the upper cervical nodal levels, like 1 to 3. Having said that, that's completely anecdotal and not evidence-based.
Got it. Yeah, I mean, Dr. Withrick, if you had a case like this, would you be more likely to radiate the nodal basin?
Yeah, I think we probably would. It would depend on the constellation of risk factors, the depth and width of the tumor and whether it had lymphovascular invasion in the pathology. But yes, our surgeons have expressed a similar concern about the maybe higher false negative rates in a situation like this. And so we would probably radiate the primary, and we would consider radiating the elective nodal basin. It also, the patient has a lot to do with it too. Their age, their ability to tolerate, neck radiation therapy, those things.
Thank you. And then one last question, unless we have any more, or any more thoughts from the group. When in your discussion, Dr. Withrick and Dr. Sheen, you might have touched on this as well. You talked about macro versus microscopic disease. Do you have a specific cutoff for nodal disease that's micro versus macro for treatment guidance?
Oh, our
So
cutoff is just if it was, I'm sorry, go ahead, Dr. Ching.
with microscopic disease, I mean, sentinel node biopsy positive patients, as Dr. Withrick was saying, if the sentinel node biopsy is positive, because the primary site usually will require radiotherapy anyway, most of our patients actually would undergo radiotherapy for both the primary site as well as the nodal basin. In patients with macroscopically positive lymph nodes, the macroscopic stage 3, that's a bit more difficult.
We're talking
There is
about
probably some low-level evidence towards a completion lymph node dissection, very low-level evidence. We're currently looking at the retrospective study looking at our patient cohort, because in Australia, in Sydney anyway, we tend to irradiate even our macroscopic nodal metastasis, whereas in the Netherlands, they tend to operate, so upfront surgery. So currently we have a retrospective cohort study to look at the data between our center as well as the ones from the Netherlands. So hopefully that will be available soon, at least as low-level evidence.
And then Dr. Withrick, do you have a pathologic cutoff to kind of delineate which route your patients take?
No, I mean our cutoff is basically if we detected it by physical examination, or if it was detected by imaging just because the physical examination was unreliable in like a very heavy patient or something like that, then that's macroscopic disease. If it was detected by solely by sentinel lymph node biopsy, then it's microscopic disease. Unless there's sort of some weird outlying feature of a sentinel lymph node with tons of tumor in it, but that doesn't really happen very often.
Got it. So you're talking more about the clinical disease than the pathologic disease in a positive sentinel lymph node.
Yeah.
Got it.
Can I just raise a point? Since we're down this, there's a whole concept of de-escalation in the neoadjuvant settings is coming actually strongly from the melanoma data. What do you guys do? And I'm Dr. Withrick, Dr. Chang. If your medical oncologist gives several cycles of immunotherapy and they have a complete response in the say the nodal basin and the let's say nodal basin, it's stage 2 disease, and they have like it's gone. GONE, the scan's negative, the ultrasound's negative. What do you do at that point? I'm not saying I know the answer, by the way, but
Yeah, at Moffitt, we would do consolidative radiation therapy at some point. We would treat them with continued immunotherapy for a certain, hopefully whatever clinical trial they were on that mandates it. But we would treat them for a certain amount of time, and then we would usually offer them consolidative radiation therapy. We don't know what to do with that scenario, which is why it's best to be done on a clinical trial so we can kind of maybe learn from that. But we're concerned about how long-lasting immunotherapy responses are in Merkel cell carcinoma, because our experience has been that we do get late relapses in patients that have a great response in our stage 4 population, for example. If they're not continuously challenged by immunotherapy, then we're concerned about late relapses. In Merkel cell carcinoma, probably even more so than in melanoma. And we have a paper that'll be coming out that talks a little bit more about that. So for that reason, we usually do consolidative radiation therapy to try to, have a final regional therapy and then put them on surveillance. But I would also acknowledge that we don't know what the right thing to do is.
Okay.
Yes.
Go ahead.
Sorry, so our neoadjuvant Merkel cell carcinoma trial is now open. So we would like, very much like Dr. Withrick, pathological specimens to confirm the pathologic response. So at present, we're still trying to not completely avoid surgery.
Yeah, actually, that brings up a good point, which is that we have also taken the the proto-melanoma approach in some of the Merkel cell carcinoma patients. So where we put a clip into like the dominant lymph node region, so that if they have a good good clinical response or good radiographic response, we can go take that lymph node and that clip out. And if there's no tumor left in that lymph node, that is pretty predictive of the rest of the lymph nodes. So we have also used sort of off trial to try to figure out how to deal with these patients. We've also used that approach from time to time.
What we do not have, however, is the incidence of disease in the non-index node, unlike in melanoma, which we have. Yeah. In Merkel cell carcinoma.
It's a great problem to have, by the way.
For sure.
All right. I think we have time for one final question. Dr. Ching, how do you counsel a patient with a positive sentinel node, specifically in regards to a completion neck dissection versus moving on to radiation therapy?
So these are in the microscopically positive patients, it's easier because they need radiotherapy anyway usually for the primary site, just following sentinel node biopsy. In the macroscopically positive patients, so without need for radiotherapy to the primary site, it is trickier, but it is a institutional. It is our institutional practice to recommend upfront radiotherapy because of the high response rate and to reserve surgery for salvage. Having said that, at present, we are trying to recruit all patients for our new adjuvant trial, so they will all be subjected to surgery following 2 cycles of nivo-rela.
Got it. And then when you're talking about, I think I've touched on this earlier, micro versus macro, only the microscopic disease would be getting a sentinel node, like clinically micro versus macro. There's no specific pathologic cutoff, in your specimen that would push you one way or the other, correct?
That's correct. Yeah.
Wonderful. Thank you all for your time and expertise. What a great group of physicians. I hope that everyone learned a lot from this panel. I know I did. And we appreciate you joining us tonight.
Thank you.
Thank you very much.
Yeah, thanks for having us. Very, very awesome.